Okay, let's quickly talk about respiratory pathology, part 1. In part 1, we are going to be trying to identify the correct placement of endotracheal tubes, central venous catheters, pacemakers, and PICC lines. Now, PICC lines and central venous catheters are going to be pretty similar. They're both lines, basically, input into a patient's vessels so that medications can be easily administered and they don't have to keep getting poked by a needle every time they need medications. That's one of the main reasons to have those. Also, endotracheal tubes. Those are tubes that go into the trachea, hence the words there, and help the patient breathe if the patient cannot breathe on their own. And then pacemakers, which help with any heart problems the patient might be having, well, certain heart problems. We also need to know the complications of improper placement. And finally, we'll need to define and describe those technique changes that we've been talking about so far this semester. So let's go on to endotracheal tubes first. Here we could see this density here, this kind of white line, is indicating our endotracheal tube. From last semester, we know that this dark portion right here indicates the trachea because it is air-filled, and air-filled structures are darker on an X-ray image. This is proper endotracheal tube placement because we can see that it ends right here above the carina. So we have 5 to 7 centimeters above the carina, which is where we want to see the tube. Now, we cannot diagnose at all or say whether or not this is properly placed, but what we can do is take a look and be aware and be really knowledgeable technologists so that we know if it's not placed properly, we can know in advance that we may need to return and take another x-ray once they've repositioned this device here. All right, so let's move on to improper CV line placement. And remember that CV there is central venous placement, central venous line. So what we're looking at in this x-ray is here. So they've inserted this line through the right arm. They should have stopped maybe about right here in the superior vena cava, but instead it's gone way too far. It's all the way here now. So what it's done is it's perforated outside of the heart, and now it is filling this entire lung with fluid. That is definitely something you do not want. All right, let's go on to PICC line. PICC line is going to be very similar to that central venous line. Now they come in through the left arm, and we can start to see it here. It's coming all the way, and it's stopped where it needs to, here in the superior vena cava. All right, finally, let's also talk a little bit about these pathologies here. So first off, cystic fibrosis. This is kind of an inherited condition, so it's mainly pediatric. It's also additive, so what that means is we're going to need to increase our technique to get a diagnostic image. Now, one thing I want to make sure you all know is when we're talking about pediatric diseases and technique changes, we always need to remember that we're only increasing our technique based on a pediatric technique. So our pediatric techniques should already be a little bit lower than an adult or standard technique. So when we say we're increasing technique, we mean increasing or decreasing later on based off of a pediatric technique. Hyaline membrane disease, that's also pediatric and it's additive. We also have RSV or RDS, or respiratory distress syndrome, typically pediatric and also additive. So all of those have that additive property in common. Pneumonia, this one we've all probably heard of throughout our lifetimes, and it is also additive. Aspiration pneumonia, that is when a person has inhaled solid contents instead of just air. So those solid contents are getting into the lungs now. Bronchiectasis, it can be both additive and destructive at the same time. So in that case, there's going to be no change in technique. Just use your standard sort of chest, even sometimes soft tissue neck, but mainly chest image technique. TB or tuberculosis is additive, or we're talking about COPD, which is chronic obstructive pulmonary disease. That's kind of a grouping of different diseases So it's kind of an umbrella. But when we have COPD combined with emphysema, we're talking about a destructive process. Same with asthma, destructive. So you're going to want to go down on technique for sure. Especially with emphysema, do not use AEC. Pneumoconioses, these are a collection of different chest or respiratory pathology based on what's been inhaled. These are discussed in your PowerPoint, and they are all additive, meaning that they need an increase in technique slightly.